So good morning to everybody in the room. Good afternoon, good evening, people who are watching on Zoom, wherever you are. Welcome. My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health, where this event is physically being hosted, although I know there are more people on Zoom than there are in the room in person. So welcome. Thank you for joining us. This event is both part of our regular public health conversation series that we host on a fairly regular basis, where we bring people who are experts in the field to talk about key issues in public health, but also the sixth in our series now of teaching public health gatherings that we've been doing for the past 6 years, highlighting key aspects that we think are relevant to the teaching of public health. You know, there is perhaps no more important time to be talking about teaching public health than it is now. We have just been through the sentinel public health crisis of our generation, hopefully, which was challenging. It was public health's finest moment, and also a moment when public health struggled. And I think we all feel, and we're all imbued with a sense of responsibility to think about how do we prepare the next generation to handle such future crises and to handle them better than we handled this one, and how do we prepare ourselves to think about what comes in the next couple of decades as we emerge from this moment. And I think gatherings like this, gatherings of people who are committed to teaching public health, to preparing the next generation, are exactly what's right in terms of focusing our thinking on how do we teach ever better. Another element of this is that this coincides with the release of the Framing the Future effort, which ASPPH spearheaded, which really pushed us to think about what are our priorities in terms of teaching of public health, and how should we make sure that those priorities infuse what we teach our students, how we prepare the next generation. All of this is going to be subject of the conversation today and the panels that we're going to be hosting here. Before I turn over, I just want to say a few thank yous. I would like, first of all, to thank our Dean's Office, our communications team, and the ASPPH staff who helped make today possible. I would like to thank ASPPH. I would like to thank Dean Laviste, who is here with us, who is the current chair of the board of ASPPH, Laura Magaña, president and CEO of ASPPH, all the ASPPH board, and all of you who are involved in ASPPH for everything that you do. On our end, I would like to thank Dean Lisa Sullivan, who is our Dean of Education, who has been the intellectual architect of our educational program, but also of this event. Thank you, and thank you to everybody for everything that you do for teaching in public health. And now it's my great privilege to turn this over to Laura Magaña, President and CEO of ASPPH, who I think has led the organization with vision and fearlessness over the past many years, with a particular focus on the importance of teaching. Laura, thank you.
Thank you, Dean Galea, for your kind introduction and for your outstanding leadership. So good morning, colleagues and friends. I am thrilled to welcome you all to today's Teaching in Public Health Conversations, where we gather to discuss transforming education for public health. In ASPPH, we are very excited to co-sponsor this event with one of our member schools, the Boston University School of Public Health, and to engage with all of you in meaningful conversations of today's. Central to today's discussion is ASPPH Framing the Future 2030 initiative. This initiative supported 3 expert panels, each of which covered distinct but interrelated aspects to manifest our vision. These panels dedicated themselves to, number 1, promoting inclusive excellence through an anti-racism lens. Number 2, embracing transformative pedagogical approaches. And number 3, nurturing robust community partnerships for the betterment of our global health landscape. The Framing the Future 2030 call to action inspires us to wave anti-racism principles into the very fabric of our educational framework, catalyze a paradigm shift in teaching and learning, and establish profound connections with communities. The knowledge that this transformative journey transcends the mere acquisition of technical abilities, it encompasses the development of human, social, and professional competencies, including nurturing civic responsibility, cultivating empathy and compassion, and fortifying resilience. Our vision aims to equip future public health professionals to lead and collaborate within an increasingly intricate and interconnected global landscape. Transforming education for public health cannot be achieved in isolation. We eagerly anticipate collaborating with local, regional, and global partners from diverse disciplines, professions, and sectors Together, we can adapt and evolve in tandem with the ever-shifting landscape of public health. Through this collective effort, we aspire to create a future where the health and well-being of communities takes center stage in health professionals' education and practice. For those of you who are speaking in panel number 1, we welcome your expertise from government, community, and industry to inspire all of us and foster deeper collaboration with academia. To the section leaders speaking in panel number 2, you are pivotal in shaping the future of your own schools and programs and beyond, and inspire all of us in our ASPPH community. So let's make every interaction today count as we strive to build environments where everyone's voice is heard and valued. To all attendees, each of you plays an integral part of this change. Your passion, your insights, and your commitment fuel our collective journey towards a better tomorrow. Let's seize this opportunity to connect, to learn, and to inspire action. Together, we can turn our aspirations into reality. In closing, I wish to express my profound gratitude to all those who have contributed to the Framing the Future 2030 initiative. In particular, Lisa Sullivan, Chair of the Steering Committee, the Steering Committee, and all the members of the expert panels. It is now my pleasure to introduce our moderators for this event, for the 2 panels. Our first panel will be moderated by Lisa Sullivan. Dr. Sullivan is Associate Dean for Education and Professor of Biostatistics at Boston University School of Public Health. In addition to be the chair of the ASPPH Framing the Future 2030 Steering Committee, she was co-chair of the expert panel that created the foundational report, Building Inclusive Excellence Through an Anti-Racism Lens. Our second panel will be moderated by Shan Mohammed. Dr. Mohammed is a clinical professor in the Department of Health Science and is the Assistant Dean for Diversity, Equity, and Inclusion and Student Initiatives at Northeastern University. He currently serves as the chair of the Education Advisory Committee with ASPPH, and it is a national co-chair of the expert panel on transformative approaches to teaching and learning with Framing the Future 2030 initiative. I look forward to both panels and will now turn things over to Lisa Sullivan. So please join me in welcoming Dr. Lisa Sullivan to the stage. Thank you.
Thank you, Dr. Magaña, for that introduction. It was and continues to be a privilege to work with you, ASPPH, and all our partners within and outside of academic public health. As Sandro noted, this is the 6th in this series, and I'm pleased to report that these conversations are very well attended, attesting to our shared commitment to excellence in teaching. We started these conversations in 2018 with a series of presentations on unique challenges faced by teachers of public health, followed by new innovations in public health teaching. In 2020, we focused on diversity, equity, inclusion, and justice in teaching public health, with discussions on inclusive pedagogy and best practices for inclusive teaching. In 2021, we focused on transformative educational models, and in 2022, we discussed teaching public health writing and communication, skills that are more important than ever today. Last year, similar to this, the conversation was co-sponsored by ASPPH, and we focused on health equity and well-being for all, and specifically on issues that the 3 Framing the Future 2030 expert panels were grappling with as they prepared their final reports. And at the 2024 ASPPH annual meeting, the reports of the 3 expert panels were released. And taken together, the Framing the Future 2030 recommendations call for us collectively to create and sustain diverse and inclusive teaching and learning communities, to optimize systems and resources to prepare graduates who are clearly recognizable for their population and public health knowledge, skills, attitudes, and practices, and to promote partnering and collaboration across disciplines, professions, and sectors. It is my distinct pleasure to be moderating our first panel, where we'll focus on extending our reach, collaborating across sectors and disciplines to support our vision of equitable, innovative, adaptive, and sustainable educational systems for public health. I'd now like to introduce all of our panel 1 speakers. First, we will hear from Kristle Hodges Johnson. Dr. Hodges Johnson is the Executive Director of University High School, a laboratory school on the campus of the University of Memphis, which launched in the fall of 2022. She has over 10 years of experience in education, beginning in the classroom as a high school English teacher, serving as a department chair and literacy coach, and transitioning into a principal role at Freedom Preparatory Academy High School. She completed her BA in English from St. Mary's College, her MED from Christian Brothers University, and her ED from Vanderbilt University. Then we will turn to Deirdre Calvert, who has been the director of the Massachusetts Bureau of Substance Addiction Services since April 2019. Prior to that, Director Calvert worked for more than 25 years as a clinical director and social worker in the Massachusetts substance use disorder system, including opiate treatment programs, residential treatment programs, and office-based opioid treatment programs. Director Calvert is also a teaching associate at Boston University School of Social Work and School of Public Health. Director Calvert holds a Master's of Social Work from Boston University and is a licensed independent clinical social worker. Then we will hear from James Stark, who works in global medical development and scientific affairs, vaccines at Pfizer. In his 10th year at Pfizer, Mr. Stark employs his creative mindset, industry experience, and epidemiology expertise to drive the medical and scientific affairs strategy for vaccine assets. He earned his PhD in epidemiology from the University of Pittsburgh Graduate School of Public Health and holds Master of Science degrees in epidemiology from the Harvard T.H. Chan School of Public Health and in molecular microbiology and immunology from Johns Hopkins School of Public Health. Finally, we will turn to Howard Koh. Dr. Koh is the Harvey V. Feinberg Professor of the Practice of Public Health Leadership at the Harvard T.H. Chan School of Public Health, as well as faculty co-chair of the Harvard Advanced Leadership Initiative. At Harvard Chan, he is the inaugural chair of the Initiative on Health and Homelessness and formerly headed the Center for Public Health Preparedness. Dr. Koh served as the 14th Assistant Secretary for Health for the U.S. Department of Health and Human Services from 2009 to 2014, and as Commissioner of Public Health for the Commonwealth of Massachusetts from 1997 to 2003. Dr. Koh is a graduate of Yale College and the Yale University School of Medicine. He earned his MPH here. He trained at Boston City Hospital and Massachusetts General Hospital and earned board certification in 4 medical fields. We're delighted to have these distinguished guests with us today, and I'll now turn things over to Dr. Hodges Johnson.
Good morning, everyone, and thank you so much for having me here. I think I am the only K-12 educator in this space today, and so I feel very honored to be able to share with you all. My name is Dr. Kristle Hodges Johnson, and I am the Executive Director of University High School, which is a public lab school on the campus of the University of Memphis. So University High School does not stand alone. We are a compendium of schools that encompasses 6 schools. When we started the university in 1912, that is when our first school started, because we were a normal school. And so that is where young educators were being trained on how to be teachers. And we started off with our flagship campus school, which is an elementary campus, and have grown to now host 3 early learning centers, 1 elementary school, and in the past 6 years, our past university's president decided to add on a middle and a high school campus in order for students to start at the university in the earliest ages from birth all the way through graduation, hopefully from the University of Memphis. And so I have the pleasure of serving in our newest campus, which is the University High School. Our schools are actually situated on the campus of the University of Memphis in Memphis, Tennessee, and that allows us direct access to the resources, to the professors, to the buildings, and all of the tools that are present on campus for our students at very early ages to begin engaging with what's happening on the college campus. So a little bit about our schools. We actually serve a little over 1,000 students from birth all the way through currently in the fall, I'll be welcoming our first junior class of 11th graders. With the students that we currently have, we are very diverse by design. Half of our student population identifies as white students, and the other half of our students do identify as students of color, and that allows us to directly reflect the diversity that is in the city of Memphis. So our student body comes from every single zip code in and around Shelby County. We intentionally do not just serve the families who work on campus at the university, which a lot of lab schools do. And we also are not a private institution where money and finances become a barrier for access for our students. And so we're serving students from every zip code, which means the most under-resourced schools as well as the most resourced schools are being represented when students matriculate to our high school campus. That also means that students who are living in low socioeconomic status environments have an opportunity to be on the campus of a university learning. So the high school we opened 2 years ago, and when we started that work, before I was actually on the team, I spent a lot of time on our planning teams thinking about what would be the core competencies that would drive some of the work that we're doing, and we settled on very early on the fact that our school would be an inclusive as well as an innovative space for students to learn. And so in the high school, no different from the rest of our campuses, we have very small schools, and so about 100 students per grade level means that we have small class sizes, which allows our teachers to have a very direct impact on what's happening in the classroom with students. And so now I'll jump in after laying some context to talk a little bit about what does this have to do with public health and why am I even here today. The dual enrollment pathways that we offer to our students allow them in the high school arena to be able to access college classes before they go to college officially as college students. That is not a new concept for schools to offer dual enrollment, but for us, specifically in this context, we offer one particular pathway that is a public health pathway, meaning that as early as sophomore year in high school, our students begin to take courses alongside undergraduate students on the campus of the University of Memphis to learn more about what public health is. Oftentimes, students don't even know what it means to study public health, to want to go into a career that is aligned with what is called public health. And so for us, we know that early engagement with what that is very important. And so I'm going to actually go backwards to go forward to explain to you all, how does a student even come to their sophomore year saying, I want to take those classes? So it was a pleasure of mine to, one, get the invitation to be here with you all today, but two, to be able to read about the great work that's happening around some of the recommendations as it relates to framing the future for public health and how our work is supporting some of those recommendations. And so the first recommendation was around building inclusive excellence through an anti-racism lens. The fact that our school populate students from all over the city of Memphis means that there is intentional diversity in how we have students come to our school, as well as the educators who are working with the students. We also have experiential learning where students have to have hands-on experience. They're not just sitting in classrooms all day. They're on campus. They're also out in the community doing work, and they're doing that alongside community partners who may not look like them, may not sound like them, and definitely have a wealth of knowledge that our students don't have yet. And the third thing that really shapes this is that volunteerism and service learning is a core part of the way that our students operate. Starting their 9th grade year, students are a part of service, whether giving back to an organization or actually going into different communities around the city to serve. 10th grade year, students actually choose a service site where they go twice a month to serve in that particular community. And that then builds up to their 11th grade year when they start to choose, where am I serving, but also where am I doing my work-based learning, and how does the work that I'm doing align with the service that I am committing to the community that I'm a part of. The second recommendation was around transformative approaches to teaching and learning. And so we know that a student would never go into public health if they don't know what it is. And so starting our 9th grade year, we do have a public health club. My esteemed colleague, Dean Joshi, who is over our School of Public Health, has worked hand in hand with us to create not only the dual enrollment courses and pathway, but we specifically talked about if a 9th grader is not exposed early, does not get to work with undergraduate and graduate students on campus, they would never be as excited to begin a part of the club, but then even taking the courses. And so the club starts very early on where they're working on campus with students who are engaged in that work. The second thing is those students get to take the dual enrollment course pathways and they're earning college credit alongside academic peers on campus. And then we also have the opportunity at this stage, as we're building out year 3, to go to the state of Tennessee and say, we want our classes for public health to be deemed as CTE courses. And so for people who are not in the K-12 world, that means that those are career and technical education courses. That means they're coded differently when students take those courses. It means that those students are going to get different funding. Our schools get different funding when we make those a priority. And so though we have some pilots happening around the state of Tennessee for students to be able to take those courses, they are not currently designated, and our school is doing that work at the state level to make that a priority. And the last thing I want to say around the last recommendation, fostering community partnerships for a healthier world. Well, one, we participate in this international competition that our School of Public Health hosts, and those are graduate and undergraduate students participating, but our high school students are participating, and we've had high schoolers as finalists in that competition the past 2 years. And so being a part of something like a hackathon for public health and thinking about what are the disparities that exist and how do we start to solve them is very critical to the work that we're doing. The second thing is students cannot go into public health without understanding that research is a priority. And so our students start to do research very early in some of their core classes in the high school, but then starting their 10th grade year, they can do research with professors on campus. And that's invaluable because not only is a student going to obviously write that on their application when they're applying to school, but having that expertise level means that they can more easily transition if they desire to major in public health. And lastly, we do have a workforce advisory board, and the advisory board that we have consists of folks like you, people who are practitioners in the field, who are clinicians, as well as people who have a deep understanding far beyond what my understanding is of what students need to know to exercise in the world of public health. And so those people advise us on which courses we're offering, what types of programs that we're offering, as well as hands-on experience students need before they graduate from our high school. I would love the opportunity to answer more questions about some of the work that we're doing at University High School, but my time is up. Please feel free to engage me today while I'm here or connect with me online. Would love to talk more about the work we're doing. Thank you.
Wow, that's going to be tough to follow. So thank you, thank you. So this is the equivalent of talking and chewing gum at the same time for me. So pushing my own slides. Hi, good morning. My name is Deirdre Calvert, and I am the director of the Bureau of Substance Addiction Services at the Massachusetts Department of Public Health. And I'm really honored to be here today at the School of Public Health discussing transforming education through public health. I'm not an MPH, I'm an MSW, which is a Master's of Social Work, but I've had the privilege of teaching here at BU for the last 3 years, focusing on mental health and addictions. When asked to speak at this forum, I really thought hard about what I could offer and what I could talk about transforming education when I'd only been at it for a few years. I then realized that I could use my years as almost 30 years as a clinician and a supervisor of MSWs and LICSWs to talk about how I engage students and professionals in advocacy issues. I approach my teaching in much the same way. I discuss advocacy through my courses, looking at harm reduction, prevention, access to naloxone, medications for opiate use disorder, and many other initiatives. But today I'm going to focus on how to engage in advocacy when looking at the failed policy on the war on drugs and what we can do to resolve this issue. So what is the issue? The failed war on drugs is truly a war on people and communities, specifically people and communities of color. The war on drugs began in the 1970s as an effort to combat illegal drug use by increasing penalties, enforcement, and incarceration of drug offenders. The war on drugs exacerbates many of the factors that negatively impact public health, and well-being, disproportionately affecting low-income communities and people of color who have already experienced structural challenges, including disinvestment, discrimination, and racism. So drug offenses still remain one of the leading causes of arrest in our nation, with over 1.1 million drug arrests in 2020, with the vast majority for personal possession. Black individuals comprise just 13% of the US population, but make up for 24% of all of the arrests in 2020, despite the fact that we have data that shows that all races use and sell drugs at the same amount. So this framework helps set up the stage for students as we begin to look at our advocacy and policy work. So, the drug supply remains unpredictable and toxic due to fentanyl and xylazine, among other contaminants in Massachusetts. In 2022, we experienced 2,357 deaths due to overdose. It's important to remember that this data represents people. When we look at the numbers that were released just a few weeks ago by the Department of Public Health that we have up here, we see some tentative relief. Massachusetts saw a 10% decrease in overall opioid deaths in 2023. That's the largest decrease that we've seen in more than a decade. But when we dive into the data and we look at opioid-related overdose deaths by race and ethnicity, we see concerning data that underscore the ongoing obligation to address the root causes of disparity, including systemic racism. So this includes addressing access to treatment and social determinants of health. Black, Hispanic, and American Indian populations continue to share a disproportionate burden of overdose deaths. So in this slide further just underscores the racial inequities that we see in the data. I swear it's all going to tie into public health in a minute. So I'm just going to read this quote from Ehrlichman. You want to know what the war on drugs was really about? The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and black people. You understand what I'm saying? We knew that we couldn't make it illegal to be there against the war or against blacks, but we knew by getting the public to associate the hippies with marijuana, blacks with heroin, excuse me, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night in the evening news. Did we know that we were lying about drugs? Of course we did. So I added this quote to illustrate how misinformation from those who are considered the top authority. This is equal to the authority that we hold as teachers and educators, and the importance of holding that authority gently and collaboratively and looking at all sides. So policies that affect the issue. So as we address inequities and overdose rates, we also are called as policy leaders and teachers to recognize and address the ongoing harms of racial injustice in the war on drugs. The data above that we just showed further emphasizes the impact of decades of state and federal decision-making led by policy and public health that criminalizes and polices substance use within communities of color. The resulting stigma, discrimination, and surveillance continues today in housing, in employment, treatment, healthcare, the legal system involvement, and it perpetuates the mistrust that we have in public health. It will only be through meaningful change in concert with systems across the educational spectrum, including in creating meaningful advocacy with our students, that we can begin to root out the racist laws, policies, and procedures that continue to criminalize substance use and to start to build that trust. So the US's drug war frontline enforcers are no longer just the police. It now includes physicians, nurses, teachers, neighbors, social workers, public health workers, landlords, and employers, and many who hold the belief that we need to have a war on drugs. So as the future public health workers, our future public health workers, our students play a pivotal and significant role in changing this narrative by working within affected communities and those with lived and living experience. Excuse me. So how do we help students better understand that community engagement and coalition building is what is needed to reach policy consensus? No good policy is created in a vacuum. Relational organizing, an especially important tool for historically neglected communities, and advocacy is just as important as subject matter expertise. We have to remember that people with lived and living experience, they're the reason that we work in public health. And this cannot be replicated exclusively in the classroom, but we as teachers are responsible for ensuring students are interested in policy advocacy. Our students are good stewards of progress and understand how to engage without creating harm and seeking common ground. So that's it. So thank you so much, and I appreciate you letting me talk about the war on drugs and be here today. So thank you.
Can you put this slide up, please? Perfect. All right. Thank you very much for the organizers providing the opportunity to share my thoughts on this public health conversation. As Dr. Sullivan noted, my name is James Stark, and I work at Pfizer in the Vaccines, Medical Affairs, and Epidemiology Scientific Affairs group. And so I'm going to take a little bit different tack because I'm going to provide perspectives on the opportunities within the pharmaceutical industry for public health graduates and able to have an impact on developing medicines and vaccines. And so because you are all the schools of public health represented, I'm going to speak directly to you about ways in which I think the graduates should be trained so that they can be then work in the pharmaceutical industry. And so there's many pharmaceutical industry roles. I'll start with my own. For example, medical affairs and epidemiology, and within vaccines, we are responsible for developing the research that can support how this vaccine can be used for the various stakeholders. And so that means we're trying to do epidemiology research to inform the burden of disease and also vaccine effectiveness studies and things like that. And we translate that, and we disseminate that to healthcare professionals and also policymakers like the ACIP. There's many roles in pharmaceutical industry that can support graduates of schools of public health. Outcomes research, health economics, clinical trials, statistics, even regulatory and public affairs, all are typically have Masters of Public Health or PhDs. So just getting directly into it, I'm going to argue now what I believe are the drivers of success for these new graduates within these roles, because I think there's a lot of opportunity for public health graduates to consider pharma as a career option. So first, it begins with expertise. A colleague hired, as we all know this, must be able to do the job that they're being hired to do, right? You have to have expertise in whether it's epidemiology, statistics, or anything else to do that. The expectation by the hiring manager is that you're able to do this and communicate that within the functional line of the program team. The way that pharma is structured, not just Pfizer, but there's a program team for all the different roles here. There is one person. That is the person who is hired. You are required to be that person. Your manager is your backstop. You must have expertise to be the epidemiologist, to be the statistician. Second, I think this goes without saying, but we've heard earlier, communication is everything. You have to be able to then communicate your functional line, your thoughts on the product, strategically and with clarity to your program team. And I think it goes without saying that every person in this room at some point in their professional career has miscommunicated at least once. And it's a constant and continual improvement that we all have. This is something that needs to be done with graduate students, and I'll explain more in a moment. Finally, perspective. It's not enough to just be an expert in your training, even though I told you you have to be an expert. You need to be more than that. You actually have to have a broad perspective on all the issues that are listed here in this program team. And so the the goal when you're on the program team and what your role is, you have to build consensus. You have to be able to say, well, from an epidemiology perspective or from a regulatory perspective, this is what we need to do. But if you want to get buy-in, if you want the other colleagues to say, you know what, the clinical trial colleagues say, I understand why you're saying that, because that's from an implementation standpoint, you need to do that. You have to understand where others are coming from. And so it's very helpful if in your training to sort of try to gain as much perspective as you can to sort of, be more strategically and better communicate within this program team. So how do you get there? What are the tools? The bread and butter of schools of public health is coursework, right? Everything that Dr. Hodges said is all coursework, right? It's like in experiential learning. So all sorts of coursework. At a minimum, you take your EPI series, you take your stats series, you take your policy series, and you become an expert in the area. The next level of coursework needs to be things that are more cross-disciplinary, that it's more solution-oriented. So, the courses that I would like to take, if I could come back, years later, after all my training, I would take the EPI series, I would take a stats series, and I would spend all my time taking classes that were co-developed by 5 departments, for example. 5 departments came together, tried to co-develop a class that was solution-oriented, that enabled you to sort of see all the different perspectives. And I'm not meaning just like a co-listing. Social behavioral sciences co-list a course with EPI because it meets both requirements. It's about 5 professors coming together, developing a class that teaches all the perspective. Second, deliverables. Students need opportunities to deliver product. And most likely that's going to be abstracts, posters, presentations, things like that. And so it's very nice to be able to have internal research days every semester at schools of public health. I did that when I was a student. Have a lot of opportunity for external presentations at conferences, which is obviously expensive, but I'm sure that there's opportunity for grants and funds like that. Because those opportunities force interaction. It encourages interaction of the students with different populations. Some of the people that you're speaking to are going to be more informed. Some of the people will be less informed. And you have to learn how to have different conversations with those people, because when you're on the program team, I can tell you the commercial colleague doesn't quite understand the clinical trial aspect or the epidemiology aspect and the medical aspect as well as someone else in that expertise. And you have to be able to have that conversation with that person to build consensus and to drive the asset and what you're trying to do forward. And there's some who have more experience, and that's a different conversation. And then finally, leadership, which I think is obvious given that what we're talking about here today. But communicating through manuscripts and posters, it's beneficial, but that is the outcome of everything. Leadership, in my opinion, particularly at Pfizer, it's developed through the process. You develop leadership through the process of actually what you're doing, bringing people along, getting there, getting them somewhere. That is influence. That is what leadership is about, at least how I see things. And so students need the opportunity to drive projects. They need the opportunity to set the agenda with their professors, with their groups of individuals who are working on projects. They need to be able to lead the meeting. And at worst, they make a mistake, and the professor pulls them aside and explains it to them. At best, they develop confidence that they learn how to develop and move forward in that area. And so I'll end, I think I have like a minute left or so. Okay. I'll end with a brief anecdote, and I will say, early in my career, I was a very junior colleague, and I had an idea, I had a proposal for this initiative, and I pitched it to the senior vice presidents, and they all thought it was great. So they said, go forward, you should do this. So I had to pull this team together of all these vice presidents, and I was many, many, many layers below that. And getting into this meeting, starting kicking this off, it was absolutely terrifying. And, but you know what, it was okay. Once I got my footing, it was okay because I realized I was actually the expert. In this particular area that I was doing, I was the expert. I had the credibility to do the epidemiology, and they knew that. That allowed me to then start building that consensus and the conversation. I also had amazing training when I was a graduate student. And in this training, I had a lot of opportunity to develop posters, not just manuscripts, posters, a lot of product, a lot of things that I could do. And that enabled me to have these conversations and to learn and to be able to have these with more senior individuals to explain to them where we needed to go. And in addition to that, through my training, I had a lot of leadership opportunities. I was sent places to have meetings, and my advisors and my faculty, they just were like, we're not coming. You're just gonna have to go do this yourself. And you just figure it out. And no one died, no one went to jail. And so I will just say that I think there's a lot of opportunity. I think the School of Public Health is doing great. I'm a product of it. I'm happy, very content. But I think there's lots of different ways that we can continue to build, particularly in the pharmaceutical industry, where I think there's a lot of great career opportunities for recent graduates. Thank you.
Good morning, everyone. It's great to see this great audience in person and online. And I'm Howard Koh, and I'm very, very grateful to be here and thankful for this national conversation on the future of public health education. I want to start by extending my gratitude to ASPPH, Dr. Laura Magaña, and Emily Burke and Liz Weist, and all the ASPPH leaders who have brought us together. And it's very, very special to me personally to have this conversation on this campus at BU, because this is where, if I can say, my medical and public health education began. I'm a graduate of this school, and getting to be a student and professor at BU School of Public Health was a pivotal moment for me. So if you don't mind, this presentation will be very personal about what's happened since then and how it's shaped my thoughts and hopefully our thoughts on the future of public health leadership education. It was great to have Dr. Stark finish his comments about leadership, because in my view, this is a theme that every school of public health should be addressing strongly and explicitly right now. And for me, the journey started only a couple of years ago when I was chief resident in medicine here at the old Boston City Hospital. Back then I was trained as all clinicians are trained, which is to be the best clinician possible. So I took that on. But during those years, I saw a lot of what I now recognize in hindsight as the social determinants of health that my patients were living through. Poverty, discrimination, lack of insurance, lack of education. They were all impacting on my patients' lives and their livelihood. And I felt so powerless to do anything about that and relatively uninformed. And then I had the incredible pleasure of and privilege of being appointed the state health commissioner by former Governor William Wells. By the way, it's great to meet Deirdre Calvert here from DPH. We just met half an hour ago, but now she's my best friend. Anybody who serves in state, federal, or local government is a friend of mine, is a hero for me. So Deirdre, thank you. And it was great to see my good friend Sophie Godley again. Where's Sophie? Who's a professor here and was at DPH when I was commissioner. Round of applause for Sophie too. Okay. So people often do not understand how hard these jobs are, how pressured they are, particularly through crises like COVID, which I'll be talking about in just a second. This all became even more clear to me when I went to join the Obama administration. And this is just one slide summarizing my incredible memories of that experience to serve under former Secretary Kathleen Sebelius. This is the start of the Affordable Care Act and the last pandemic H1N1 to support the then president and then vice president, now president, and their priorities during that time. Was an incredible privilege to serve on the top right as part of the World Health Assembly team that was in Geneva to sit behind a placard that said the United States of America as a Korean American is just an incredible privilege. And then I just want to honor my colleague and friend, Dr. Tony Fauci, who we all know so much about, who is such an incredible leader in public health history. But those memories are all in my head as we now face educating public health students and leaders for the future, because we are in a very difficult time. Last year in the journal Health Affairs, I had the incredible honor of being senior author on this paper entitled, as you see here, The Exodus of State and Local Public Health Employees. Separation started before and continued throughout COVID-19. Our analysis, which was led by Dr. J.P. Leiter of the University of Minnesota, also involved Brian Castrucci of the De Beaumont Foundation, Mike Frazier of ASTHO, and other colleagues, found that through COVID, half of state and local public health officials left. They either resigned, they were fired, they were having real struggles going through very, very difficult pressures. And we all understand why, and that's what's driving us to have a meeting like this to prepare what's going to come next. In my view, we need more attention to what I call crucibles of leadership. Supporting people as they address public health as a career, understand leadership as a critical, important challenge and opportunity. Teaching our students that there are going to be many moments of adversity, but helping leaders reframe to create new meaning so they can keep going. And if you do this right, you see leaders who emerge stronger and more committed than ever before. And so during my time in government, particularly at the state and federal level, I started thinking a lot about leadership, topics that I hadn't heard very much in my medical and public health education. Don't get me wrong, I love this school, but back then especially, I did not hear much about that. And in my view right now, in 2024, all schools of public health and medicine should have dedicated curricula and programs on leadership. When you start teaching this area, it gets very fascinating because there is no one definition of leadership. So you can start any course or class by saying to the students, hey, what is your one-line definition of leadership? Let's put it together and discuss it and debate it. So that's how I start my leadership course every year. I collect several dozen of my favorites. So here are just a couple to put before you for discussion and debate, if you will. The job of the leader is to speak to the possibility. That's proposed by Benjamin Zander, a world-famous conductor and musician, not a public health guy, but a leadership figure, undoubtedly. Steve Covey, the leadership guru who wrote the famous book, 7 Habits of Highly Effective People, had this great line, leadership as a choice, not a position. More on that later. Here's one of my favorite definitions of leadership from Kouzes and Posner, who've written the classic book on leadership. Leadership is the art of mobilizing others to want to struggle for shared aspirations. It's an art, it's definitely not a science, and you want to support people to struggle for higher aspirations. It's about inspiration, it's about aspiration, it's about perspiration. And then this is tough stuff. Here's this wonderful quote that my great colleague Mike McCormick once gave me, and I never forgot. Leaders are called to stand in that lonely place between the no longer and the not yet. That's where we are right now with COVID, with 1.2 million deaths and counting. What's going to come next? We're in that lonely place. We have an opportunity right now with the leadership of ASPPH to try to plan this together going forward. So what is leadership all about? Let me just show you in one slide, one slide what I think it's all about. Because our field is infinitely broad, it's infinitely complex, it's infinitely interdisciplinary. The more you can get out of the health and medical world and reach out to social workers and high school educators and business leaders and faith-based leaders and on, I think the better off you're going to be. When you bring people together to face a tough problem like the overdose crisis, like Deirdre just summarized, everybody comes in with their own view of where true north is, where we should be going. And your job as a leader who can't be an expert in all this, to align people, to do that. Did you like that? I'm going to show you that again. I'm so proud of that. Thank you. By the way, I work with a wonderful deputy, Kirk Vanda, who does all my slides. He's got another one coming up. I'll show you in just a second. Okay, and then some basic concepts. When you do this work, you start studying what other colleagues in leadership teach, and if it resonates with you and your students. I have a wonderful colleague at the Harvard Kennedy School, Marshall Gantz, who has written that leadership requires head, heart, and hands. That's fascinating. When you think about it, if you get involved in leadership education, we often talk about the head and the hands, the how and the what. But we talk less often about the heart, the why of why people would even want to get involved in this stuff at the beginning when it's so hard. So over time, I've gotten fascinated, along with my colleagues at Harvard, I'm going to be bragging about them in a second, about the heart, the why people get involved. And relevant to that is a fascinating book in leadership in the business world by Simon Sinek. And the book is entitled Start With Why. So this is very simple. In this picture on the right, he writes that when people are thinking about leadership in business or education or the military or other areas, they often start with what or how. But if you go deeper, the why is in the middle of it. And he suggests that we should start with why, start from the inside out. So the more I do public health leadership teaching, I want to know why the students are there, why they want to commit to getting involved in such a tough area at such a tough time. And it opens up conversations and builds connections, I think, in fascinating ways, and it gets people in touch with what brings meaning and purpose into their lives. And so I have come to the conclusion in my career that public health is basically a career that involves vocation and calling. And I've gotten fascinated with that theme. There's an author named Parker Palmer who has written written a book called Let Your Life Speak. He says vocation does not mean a goal that I pursue, it means a calling that I hear. If I can say that's the only way I can explain my career right now. I never dreamed I'd be in public health. I never dreamed I'd be in leadership positions at the state and federal level. I never dreamed I'd be a professor of public health back when I was training on this campus. Back then, I just wanted to be the best clinician I could possibly be, and that's fine. But I always felt there was something else. And looking back now, I was answering a call. And you know what? This is reinforced for me every year when I have incredible honor of speaking on the first day of orientation to 500 new students who come to our school, the Harvard Chan School of Public Health, from around the world. And I put up one of those poll everywhere questions, and I asked them to choose, by taking out their cell phones, between 1, I always knew I wanted to go to a school of public health, or 2, I never imagined I would attend a school of public health, but here I am. So I made this up, by the way. First time I put it up, I held my breath. Okay, how's this going to be? But now I've done this 4 or 5 times. The answer comes out always the same. It's about 2 to 1, B. I never imagined I would attend a school of public health, but here I am. Tell you what, at your next public health party, just ask that question. It's fascinating. And then when they answer B, like I did, and I do, you ask them why. How did it happen? What drew you in? And they'll often say something like, oh, you know, there's this issue and it spoke to me and I couldn't let it go and I was trying to do this, but I felt called to do that. To me, that is vocation, calling, spirituality, and a theme that I'm now absolutely fascinated by. And by the way, the best quote about vocation and calling I've ever heard is from Oprah Winfrey, okay? She spoke at a graduation a number of years ago, and this jumped out at me, so I'm going to read it to you. There is a sacred calling in your life, and the question is, will you spend your life flittering and fluttering about, or take the time and really heed that call and create your own path to your highest good? I think that's what we're trying to do in public health. And then in classic Oprah style, she's a fantastic leader and communicator, of course, real power is when you're doing exactly what you're supposed to be doing. There's a kind of energy field that says, I'm in my groove, and nobody has to tell you, you go girl, because you know you are already gone. How does it get better than that, right? Okay, so since coming back from DC to Harvard, I have gotten fascinated with the concepts of vocation, calling, leadership, spirituality, and how it all intersects with public health. We have a Harvard initiative on health, spirituality, and religion, and I show my great colleagues who I've had the honor of working with since I came back 9 years ago. And this is an interdisciplinary group from the public health school, the medical school, the divinity school, from McLean Hospital, from the Brigham and Women's Hospital. We have a chaplain here. We have an epidemiologist, biostatistician. We have a psychologist from McLean. And so we've written a couple articles I'm very, very proud of about the overlap between spirituality and health. There is a consensus conference on how to define spirituality, by the way, if you're thinking about it. And the key phrases are in bold. It's what has to do with ultimate meaning, purpose, and the significant or sacred. What's your connection to something bigger than yourself? I believe that we are all in public health because we just have that strong call that there's something bigger and we want to be part of it and we want to contribute to it. I'm particularly proud to mention this group because just a week ago in Health Affairs, in their issue on reimagining the future of public health, we wrote an article. Again, I had this honor of serving as senior author, and Kate Long, who's pictured here, was the first author, entitled Spirituality as a Determinant of Health, Emerging Policies, Practices, and Systems. So if you have time, please look it up. Kate is right in the middle of the pictures here. You'll be very proud to know that Kate got her DRPH from the Boston University School of Public Health, okay? And then as I kept thinking about this, I said, boy, this really ties in with public health leadership. So last year in Frontiers in Public Health, I and my great colleague Fawn Phelps and a couple other colleagues who I'll be talking about later wrote this article, Exploring the Spiritual Foundations of Public Health Leadership, that was published in Frontiers in Public Health. So we're very, very proud of that. It's gotten a very positive reception so far. I think we were the first to address the intersection of all those themes, so more on that later. So right now, as I wrap up, at the Harvard Chan School of Public Health, I have the incredible honor of working with a number of extremely dedicated colleagues who are teaching and coaching on public health leadership. There are pictures of three down the bottom. Fawn Phelps, who is Director of Public Health Leadership Education. Bill Bean, who is one of our most revered professors and teachers and coaches. Ted Witherall, who also does a lot of teaching on public health leadership at our school. Fawn and Bill are here. Can you just raise your hands and get a round of applause from everybody? Thank you. And I think Ted might be on his way, maybe not, but he does a lot of work for us. In anticipation of today, we just summarized for you one slide the many things we're trying to do at our school. The required MPH course on leadership and communication, a public health leadership lab, which is extracurricular. It involves students of all concentrations, lots of emphasis on coaching. Fawn heads this. Over on the right is a celebration picture of about 50 people in that lab going through a team-based exercise. We have a Doctor of Public Health program, as you do, lots of emphasis on coaching. We have a Menschel Fellowship program that brings in governors and mayors from the outside. We ask them to teach leadership and ask them to share their why. And we also move into executive leadership coaching and teaching as well. So we can talk more about that later. And so for all these reasons, I was absolutely delighted when Emily Burke of ASPPH asked me to chair last year a new public health workforce task force to talk about the future of leadership education in public health. We are going through a framework and competency mapping effort around a framework on the right about leadership being about person, problem, pathway, and also purpose. And we have our goals to put this down on paper and try to start a national discussion among all the schools of public health. And then, by the way, we are happy to announce that through our collaboration, the Journal of Frontiers in Public Health will soon be asking for dedicated articles on public health leadership. And Emily and I and Professor Louis Fry and Fawn will be co-editing that going forward, so stay tuned for that. So as I close, how do we get our students to start thinking about these themes about resilience, flexibility, perseverance, and how do they keep that in perspective as they're going through schools like this one? Here's some more incredible quotes. I won't share all of them. Here are a couple of ones I love. One by my mentor, Reverend William Sloan Coffin from Yale. This is where my journey began, by the way, years ago. He used to say, "Blessed are the flexible, so that ye shall not be bent out of shape." I can't think of a more appropriate comment for public health leaders for the future. And Bill also used to say, "Giant obstacles are brilliant opportunities, brilliantly disguised as giant obstacles." When you get people together and you're trying to face some really tough challenge, climate change or COVID or opioids or whatever, how can you find those brilliant opportunities inside? And then to all the students, I often hear, "Oh, well, Dr. Coe, this is interesting, but, you know, I don't have a fancy position, and I don't have money, I don't have budgets, I don't have any power, you know, I got to wait for 10, 20 years to even start thinking about this." And I said, absolutely not, because all of us have a circle of concern, which is broad, and then a much smaller circle of influence. And if you focus on your circle of influence and be effective, guess what happens to your circle of influence? You ready? You like that? That's from 7 Habits of Highly Effective People. Again, thank my deputy Kirk Vanda for creating that. And I love that so much I'm going to do it one more time. Okay. Okay, so I think we're nearing the end. Here's my last slide. Of all the leadership teachings I share with my students, I think this is the most important one, and this comes from Maya Angelou, a brilliant, brilliant author. Quote, "I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." Think about that for a second. In my view, that's what public health leadership is all about. So thank you very much for your time and attention.
Thank you. We have a short time for some questions, so I'd like to ask all the speakers to come up to the stage. I'll start with a question, and then we'll turn to the audience. And for people joining virtually, we ask that you submit questions using the Q&A function at the bottom of your screen. So I'll just kick off with one question. As Dr. Magaña started us off, the Framing the Future initiative is a call to action. It's bold and complex, and the landscape within which we're working is changing. Do you have advice for academic institutions as they plan to implement significant transformation, particularly related to the communities they serve?
I can start.
Please.
That's okay. Well,
Please.
so one of the things that I mentioned briefly was getting people with lived and living experience have to help us develop policy and procedure. And I was listening to all of my co-presenters today. I remembered something that happens quite frequently in addiction is that we build policy based on, I know a guy. You know, it's the only field basically. You know, it's like, well, my family member went to AA, so now everybody has to go to AA, or my family, you know, didn't get sober through medications. But we have to have people with lived and living experience help us guide the way. And I think that that's one of the things that we have to bring to the classroom.
Thank you.
I can say I support that 1,000%. One of the new efforts we have in our school is an initiative on health and homelessness, one of the toughest public health challenges out there. You know, we're across the street from Mass and Cass and the Boston Healthcare for the Homeless program that we're partnering with very closely. And if you start by working with people who have lived experience and learn from them and respect them, that is a major, major step forward. And then just to repeat some of the themes I think we've heard already, to make such efforts as interdisciplinary as possible and try to align people is hugely important. So those are some of the things that go through my head as I hear your question.
Thank you. Thank you. Audience question? Go right ahead.
Hi, I'm Janice Skibber from the University of South Florida. I have a question, I think for Dr. Coe, but I'll take the answer from anyone. So we started introducing leadership coaching into our DRPH program in full force this year. We have great coaches and they're doing a wonderful job, but the feedback from our students is that this is all fluff, this is nice, but we need to do our coursework. So, you know, I appreciate your message about the circle of influence, but I wonder how we get across to our DRPH students who are already leaders in their own field and they're back for a leadership degree. How do we convince them that there's more than coursework to their degree? I know it'll be one of those situations where they'll thank us later, but as we navigate this feedback, how do we answer that fluff question? question.
Thanks for your question. I'm going to embarrass and thank my wonderful colleague, Fawn Phelps, because she leads our public health leadership education efforts at Harvard. And she and I insisted when our DRPH program was started a decade ago that coaching be integral from day one. And in the now 10 years of our DRPH program, which I can't believe, and actually Dean Julio Frank asked me to come back to help start that. When we survey our graduates, they point to the coaching as perhaps the #1 thing they're most grateful for about our program. That somebody's caring about them, is listening, is being a mirror and reflection to them. And you know, this, if you tackle leadership, this is a lifelong endeavor, and it's almost impossible to have perspective on it. This is where a beloved family member, a spouse, somebody who loves you and cares about you, somebody who is willing to coach you makes all the difference in the world. By the way, this is the time when I thank my incredible wife, Dr. Claudia Arag, who I met on this campus, by the way. Another reason I'm grateful to be here. What she has lived through listening to my stories at night in my various capacities and just trying to give me some objective feedback is just invaluable. So I'd be happy to hear how it goes going forward. I'm going to guess that if I talk to you in a couple of years, your students may be telling you a different theme. And if you don't know more, please talk to Fawn, who's right here.
There's a question.
Hello, my name is Zach Orlov. My studies were done at the University of Rochester. And my question is identifying the beginning and drivers of homelessness. In your examination, does that perhaps reveal what solutions might look like?
Yeah, absolutely. So that's a simple question and a very hard answer to deliver. And it's so complex. A major fundamental driver is lack of affordable housing, of course. And it's been explained to me that this crisis, which is affecting all parts of the country, by the way, we got involved in this because this was in the news every week, every part of the country. And I said to myself, this is a public health crisis. How come public health schools and medical schools aren't talking about this? So we started several years ago. But one of the major drivers is lack of affordable housing. It's like a game of musical chairs where, you know, every once in a while another chair gets taken away, so somebody is left without a chair, i.e. a house or a home. And then as the gap gets worse, more and more people are left to fend for themselves, often on the street. And you can imagine the people who are most vulnerable, those wrestling with substance use or who have disabilities, are the ones who are most likely to fail at the musical chairs game of housing. So that's one driver. But then it's complicated by the disabilities, physical and mental, the lack of social supports. The other thing I'm learning by working with my colleagues on this is that when you see people who are wrestling with homelessness, a lot of them have endured childhood trauma. They have incredible stories of adverse childhood experiences. That's the tough news, but the inspiring news is they're still getting up every day, trying to get back on their feet. You know, they need some support, they need some understanding. They need people not to walk by them when they're out on the street, literally on their last legs. And they represent, in my view, a lot of systems failures in our society, all converging on these vulnerable people. So those are some of the discussions we're having as we do our initiative, and would be happy to talk to you more about that.
Can I add something on that? I'm sorry.
Oh, good.
Oh, so from substance use perspective, housing is seen as a reward. You stop using, you act behaviorally well, you are then rewarded with housing, and that is in our federal government, in our HUD housing, that if you relapse or you transiently use, you lose this very basic right. And so we have these, it's the only disease in the world where we think that you have to have perfection. We wouldn't do that if you stop taking your blood pressure medicine, if you stop taking your diabetic medicine, but we have to stop looking as a reward, but as a actual human right. And that we can't say, when you're sober, when you reach the recovery that I've decided that you can have, then you may now have access to this fundamental, thing that's going to help you. So I want to say we have federal laws and state laws that still discriminate against people to access the very limited housing that we're talking about. And so our Bureau took it upon ourselves in 2021 to start housing people regardless of whether or not they could sustain their sobriety. And we have, we've permanently housed the people that you see outside, permanently housed 600 people in the state of Massachusetts, permanently where sobriety is not a requirement. And they do not have to reach this level of perfection, but they are all deserving of a place to live.
Thank you. Thank you. Next, yes.
Thank you. I'm Elizabeth Baker from East Carolina University. And I had a question. I'm very interested in this intersection between the pharmaceutical industry and public health. My experience throughout the years is that there's a diversity of perspectives on in some ways how they either contradict or complement each other. And one of the examples from my own work is while I was at USF, talking about the feminization of the HPV vaccine and how that communication was really detrimental in terms of continuing to roll it out as we develop new technologies. What I'm curious about, and I appreciate how you laid out the different ways that public health can get involved, but what is your recommendation for maybe smaller programs, for example, who maybe don't have strong connections with someone in the pharmaceutical industry, and how to start networking and making those connections to help bring about those opportunities to better understand how they can participate?
Great. Thank you for the question. So I will start by saying, which doesn't directly answer your question, but here at in Boston at the BU School of Public Health, this year we started an inaugural cohort of 7 graduate students who are completing their practicums this summer with Pfizer Vaccines, Medical, and Scientific Affairs, and we're hoping to extend that for the next several years, made by a grant from Pfizer to BU School of Public Health. And so that gives them an opportunity to have a paid practicum, get real hands-on experience, and really have the opportunity to learn some of the things that, take the coursework, translate it to sort of what the real world is. I think there is a gap in the relationship between universities and pharma, as you say, even the bigger schools, but also certainly the smaller schools, because I do think it's a rewarding path. For some people, it's a calling, and so I think obviously for schools that are you're locally based. There may not be a pharmaceutical or biotech company that's sort of nearby. I think one way to sort of make those connections would potentially be to attend the conferences in the places where pharma goes, and rightly or wrongly, although my group does this, we don't necessarily present at APHA, for example, right? Some of our things need to be a bit more tailored, a little bit less broad and diverse. And so we typically go to conferences like IDSA's ID Week, conferences that are more tailored for where, or ASCO for oncology products, tailored for where our products would be, our medicines and vaccines would need to be showcased, if you will. And I think there's a lot of opportunity there. We send massive contingents of colleagues to those, and I think that's where you can start making some connections, but happy to discuss afterwards as well.
All right, I'm so sorry to do this, Leah. Last question. Yes, you will have the last question, and then we have to move to a break, so go ahead, and hopefully the conversation can continue during the break. Go right ahead.
Hello, everyone. Leah Neubauer, Feinberg School of Medicine in Chicago. It's a reflection and a question on coaching. My reflection is very shared, I think, with the comment shared earlier, DRPH. Did the coaching feel less than, or we should spend our time in courses? I've been across 3 CEF accredited institutions,
and have heard similar things from our MPH students when we tried to integrate a professional practice seminar. So something that's integrated and nested with a practicum experience, serving some clear supervision, focus, or focal areas, but also mentoring, advising. We've heard the same, then we've made it 0 credit hour, and then it wasn't worth it. And so all the things, I coach, right? I coach youth. I came to coaching as an athlete, positive youth development, pipeline and pathway programming, Boys and Girls Club. So my reflection is that experience, my own. And so my question to you all here is there thought to a more educational lifespan approach? So by the time I might receive, right, my students at the master's or doctoral level, there could be more integration perhaps in high school, although I sense it already is, which makes me wonder, what are we doing at the bachelor's level? Or should we be doing something at the bachelor's level to integrate that same type of thinking? Just as I learned from my educators or my auntie or my grandmother or my sports coach, it's happening at that level as well. So I just wondered if there were any reflections or if that might be what the task force is looking at. But again, what might we do more so it feels normal to learn kind of with others, perhaps, and to receive critical feedback?
Thank you. I'm delighted this topic is getting so much attention. You know, under Fawn's leadership, we have a lot of attention to, first of all, peer coaching. So if you've never been a student who tried to coach a peer, you get taught that and then engaged in that immediately. You got to show your leadership skills immediately to be a empathic and compassionate and effective peer coach. And then under Fawn's leadership, she's recruited wonderful coaches like Bill Bean and Ted Witherall and many others. And then I'm hoping this will be a lifelong source of reflection and inspiration, because let's face it, if you do public health, you're going to face all these decision points over many decades if you have the privilege of living that long, and you try to make critically important decisions based on what you think your values are and what gives you a sense of meaning and purpose. Having a good coach, somebody who cares about you, whether it's a family member or a spouse or somebody you met in school who's a lifelong friend, can be just an invaluable resource. So you can tell I'm a big proponent of it. At the break, please talk to Fawn Phelps, okay? She's the expert on all this, so thank you.
Is anything happening at the high school level with coaching?
Yes, so our students start work-based learning their 11th grade year, and in that phase, they do have mentors. Mentors that hopefully would connect with them based on the career field they're interested in going into, but some students don't know yet. And I think to the question that was asked, what I know to be true of working with younger students is that you can't teach people to value humanity. Sometimes people just need to live long enough to understand that their humanity matters, and then how it shows up in the work that they do will look different over time. And I know that that is not a surefire way to get students excited about being in particular classes or programs, but from the high school lens, I have had students to sometimes come back to me 2 years after graduating and sometimes 10 years after graduating when they eventually understand why having that particular mentor was important, or what some formative teacher told them was going to now have a deeper impact on the work that they were doing, or career changes that they've made. And so I think that make people have the mentor, have the coaching, and stick with it. But if we are waiting for a survey to tell us that people appreciated it in the moment, I don't think that that will always happen, especially I think with this particular generation that we are serving and have the opportunity to lead. People want to move faster to higher paying positions, to things that look meaningful to them on paper in terms of titles and positions. And so help them get there. I think that what James was saying is absolutely correct. Train people on how to do the things, get to the deliverables, but in the meantime, keep coaching them and mentoring them, and I think eventually they will get to understanding why other people being interconnected was so important to how they do work at some stage in their career.
Thank you all. Thank you all for your presentations. We are going to take a very quick break and return in a few minutes for panel 2. Thank you, everybody.